We are moving on to the subsequent interstitial lung diseases. In that, one of the important things are the occupational lung diseases. Basically, occupation-related diseases can be divided into two, either due to inorganic dust or maybe due to organic dust. If it's happening due to inorganic dust, we call them as pneumoconiosis, which means these ILDs are occupational lung diseases that happen due to inorganic dust particles like silica, asbestos, coal particles, or beryllium, or even a talcosis. But these are the four most important things that we are going to discuss in this particular video. Before going into that, let us classify the particle size, the dust particle size, and let us see which are dangerous and which are not dangerous and what are the characteristics of these particles. First, let us see the size of the particle and where they will deposit and how they are cleared. There are many different sizes of the particle. The first size I am going to tell about the large particles, which are more than 10 micrometer in size. Then you have medium particles, which are approximately 6 to 10 micrometer in size. And you have small particles, which are 1 to 5 micrometer in size. And you have very small particles, which are less than 0.5 micrometer in size. In this, the most dangerous particles are the small ones. Let us see why. This is because they deposit in the respiratory bronchioles and the alveoli. And they are very, very difficult to clear. Very, very difficult to clear. If it's difficult to clear, means it's going to elicit an inflammatory reaction in that area. That is the reason why the small particles are the ones which are going to be heavily dangerous. Very small particles, no issues, they will be depositing only in the alveoli and they are cleared by alveolar macrophages itself. Alright. Similarly, very large particles are also very easily cleared because they don't come till the level of the alveoli itself. They will be deposited only in the nasal cavity most of the times, and just by nasal vibrissae itself, they will be cleared. All this hair entanglement, lot of other actions are there in the nose itself, that itself will clear these particles. And medium particles also maximum they are going to deposit in the trachea and in the bronchi, maybe maximally in the proximal bronchioles. But again, these particles are easily eliminated by your mucociliary escalator action. So, all these three are very easy to clear. The most difficult to clear will be the small particles of 1 to 5 micrometer in size, and many times these particles fall under this category, that 1 to 5 micrometer in size, that are the small particle size. So, that is where the problem is going to be in this particular particle size. Fine. Now, let us see an overview of what all these disorders are concerned with. Maybe as we move along with the video, we will be discussing each and every single occupational lung disease and pneumoconiosis, but let us see an overview right now. So, let me put 4 disorders. You have silicosis, you have asbestosis, you have coal workers pneumoconiosis, and you have berylliosis. So, first thing, you have to see which is the most common one. Obviously, it is going to be silicosis. Silicosis is the most common pneumoconiosis in the world, and it's the most common occupational lung disease in the world as well. Coal is not the most common right now. It was once upon a time most common, but right now it's not the most common. The silica is going to be the most common form of pneumoconiosis. Secondarily, what are things you might result? First, let us see whether this will cause ILD or not. Yes. All of the pneumoconiosis can cause an interstitial lung disease, but which is having the highest risk, highest chance is for the silicosis. Asbestosis and berylliosis has a moderate chance of developing ILD, whereas coal workers pneumoconiosis has the least chance of developing a interstitial lung disease, which means coal particles tend to be the least fibrogenic. Whereas one particular particle in the silicosis, that is called quartz, is going to be the most fibrogenic or strongest fibrogenic substance in the world. So that's why ILD is very, very common in silicosis compared to other disorders. Then let us see whether they can cause tuberculosis or not. Is there any high risk of developing tuberculosis in these patients? Silicosis, yes. Asbestosis, coal workers pneumoconiosis and berylliosis, really no. Clear? So this kind of tuberculosis that is produced because of underlying silicosis, we refer to as something called as silicotuberculosis. Alright. Third, whether they can develop cor pulmonale or not? Yes, all of them can develop cor pulmonale once they develop an ILD. Because if there is an ILD, obviously if you don't treat that, they're going to go for cor pulmonale. Fine. Then, whether they can cause lung cancer or not. Primary lung cancer. Yes, all of them can cause primary lung cancer, but the least is for the coal workers pneumoconiosis. In fact, certain old textbooks like Crofton give the fact that coal workers pneumoconiosis do not develop lung cancer at all. But this fact is not really true because there are a lot of modern studies which clearly tell there is an occult cancer that is present in these patients as well, which is very slow growing. That's why probably the patient die of ILD and progressive massive fibrosis rather than the lung cancer, which is very small at the time of death. So probably that is the reason why it is underestimated. Many recent studies have used PET-CT where they have demonstrated an active area of uptake which is proven to be the cancer in the subsequent investigations. So cancer is possible in a coal workers pneumoconiosis also, unlike your old textbook which are mentioning cancer is not possible in coal workers pneumoconiosis. But you can think that the cancer is having the least likelihood of development in a patient who is having a coal workers pneumoconiosis compared to other patients. Typically, about this lung cancer, you have to know some important points. The first one, what is the most common type of lung cancer? That is non-small cell lung cancer, especially it's going to be adenocarcinoma. This is going to be the most common type of lung cancer that usually happens in patients who are having a pneumoconiosis. And one more important thing is the fact that smoking dramatically increases the risk of developing lung cancer. Usually lung cancer happens after 10 to 15 years of getting a pneumoconiosis. But this development of this lung cancer can be accelerated. The duration may be less, the latency period may be less. At the same time, it can increase the risk dramatically when the patient smokes. So smoking is a definite etiological association with this primary lung cancer, especially in a patient who is having a pneumoconiosis. So please ask these patients not to smoke, which is a very important part of the treatment. Next is, you can talk about a mesothelioma. Again, you know the fact that mesothelioma is an exclusive tumor that is related to asbestosis only. It's not going to be seen with any other disease, any other pneumoconiosis. Only asbestosis is going to pose a risk of mesothelioma for sure. And the latency period for mesothelioma is going to be very, very high, which means I told you for lung cancer, it's around 10 to 15 years or 15 to 20 years around. But this mesothelioma has a latency period of very, very long period, that is around 25 to 30 years. And if you ask me, even in asbestosis, the most common cancer that happens in these patients is going to be lung cancer only. It's not going to be mesothelioma. Mesothelioma is exclusive for asbestosis, but it is not the most common tumor that is going to be seen in asbestosis patients. Still, it is the lung cancer that's going to be the most common in asbestosis patients as well. Clear? And let us see the association with the particles and all in the subsequent section. I'm not going to discuss about those right now, but let us see later on. And finally, do you have any association with smoking and mesothelioma? Actually, no. There is no etiological relationship with smoking at all. Very, very important point. I told you Definitely, smoking further increases the risk of developing lung cancer if the patient has a pneumoconiosis. But smoking does not have any etiological association with mesothelioma, only asbestosis. Even if the patient smokes or doesn't smoke, doesn't matter. They still do develop mesothelioma if they are at risk of developing mesothelioma. If they are destined to develop mesothelioma, smoking will not increase the risk of developing mesothelioma even in a patient with asbestosis. Clear? Then, whether they can develop this Kaplan syndrome or not. Yes. Ideally speaking, all of them have a risk of developing Kaplan syndrome. First of all, you have to know what do you mean by Kaplan syndrome. Kaplan syndrome means you have an underlying pneumoconiosis. This pneumoconiosis definitely increases the risk of developing rheumatoid arthritis. It's a very important environmental risk factor for developing rheumatoid arthritis. Usually a pneumoconiosis is a risk factor for developing pneumoconiosis, which we'll be discussing in the rheumatology section. So if a patient develops rheumatoid arthritis, there are high likelihood that they're going to develop rheumatoid nodules in the lung. And these rheumatoid nodules in the lung is typically going to be in the upper lobe. At the same time, you know that this patient also has a underlying pneumoconiosis. And this combination is what we refer to as Kaplan syndrome, which means the basic necessity for developing a Kaplan syndrome is a pneumoconiosis, not a rheumatoid arthritis. Clear, the pneumoconiosis increases the risk of rheumatoid arthritis in the future. And once the patient gets rheumatoid arthritis with an underlying pneumoconiosis, and if they develop RA nodules, which is typically in the upper lobe, along with the pneumoconiosis, that's going to be called as Kaplan syndrome. Clear? So, which is the commonest lobe? Silicosis is going to be common in the upper lobe. Kohlwacker's pneumoconiosis is going to be common in the upper lobe. And berylliosis is also going to be common in the upper lobe. But one disease that's going to affect the lower lobe very, very commonly is going to be asbestosis. This is also an important difference that you should know for sure. So, very, very important. Clear? Multiple times asked question in the exams once again. And the treatment for all these disorders is the fact that there is no treatment. Prevention is the only key. You have to prevent these disorders. That is why you have labor organizations nationally as well as internationally. So these are labor protective organizations that have some guidelines that has to be followed in many industries and many factories where they have to give this personal protective equipment to prevent these disorders, because it's definitely there's no treatment for that and the only way is prevention. And all these patients has to be advised to quit smoking or to avoid smoking if they are not smoking already, because that is going to dramatically increase the risk of developing lung cancer as well. So these are the general aspects of all the pneumoconiosis. With this, we'll move on to the most common occupational lung disease in the world, that is silicosis. Risk factors for silicosis, you have a lot of risk factors. For example, this quartz exposure is very, very common in patients who are working in mines. There are certain foundries that cast metal. So again, there is a high risk in those areas. And in Turkey, one incidence has been demonstrated in the form of sandblasting of denim jeans, especially in Turkey. This is proved actually. So this also is one area where you can get your silicosis. And at the same time, you can also develop during hydraulic fracturing. This hydraulic fracturing for natural gas is one of the very commonly employed procedures in many different countries, in many different areas. Usually they do in driest areas where they don't have any agriculture going on. So this hydraulic fracturing, so they will take up the natural gas. That time they let out a lot of water underneath. At the same time, they're going to take up the natural gas and use it for commercial purposes. So during those times, you are going to blast a lot of amount of sand. At the same time, you're going to remove a lot of water out. That time, a lot of sand is going to come again. And that's also a risk factor for developing silicosis. So these are some of the risk factors for developing silicosis. Alright, as I told you already, this quartz is supposed to be one of the most fibrogenic particles in the world, whereas coal dust is one of the least fibrogenic particles in the world. But this silica particle, that is quartz, is going to be the most strongly fibrogenic particle. And there are 4 types of silicosis there, and 4 types of diseases in fact is there. So what are the 4 types of diseases? One is called acute silicoproteinosis. Acute silicoproteinosis. Second one, you have chronic simple silicosis. Then you have chronic complicated silicosis. Then finally you have accelerated silicosis. So you have acute silicoproteinosis, you have chronic simple silicosis, you have chronic complicated silicosis, and you have accelerated silicosis. So let us see the latency period of all these things. Acute silicoproteinosis happens within a few weeks of exposure. Chronic simple silicosis is going to happen after 10 to 20 years. Chronic complicated silicosis also happens approximately in 10 to 20 years mark, whereas accelerated silicosis is going to happen within 3 to 10 years mark, which means you can see all of those disorders are actually chronic disorders only. The only thing that presents acutely is the acute silicoproteinosis, as the name suggests itself, acute silicoproteinosis. What about the exposure level? Exposure level in acute silicoproteinosis is going to be extremely high level exposure, whereas for accelerated silicosis, it's moderate to high level exposure, whereas chronic simple and chronic complicated silicosis, it will be only low to moderate level exposure. Low to moderate level exposure to silica dust. That's it. And you have some clinical features for the same. So what are going to be the clinical feature? The first, acute silicoproteinosis is going to present with rapidly progressive shortness of breath, with cough. At the same time, they might even have a productive cough. I'll tell you why. Whereas chronic simple silicosis, they tend to be typically asymptomatic, or very rarely they have shortness of breath and dry cough. Chronic complicated silicosis, definitely they will be symptomatic because it's a little bit of complicated, bigger fibrosis compared to chronic simple silicosis entity. So that is the reason why usually they present with shortness of breath and dry cough. At the same time, they'll actually be functionally impaired, which we'll discuss. And in accelerated silicosis, again they'll be symptomatic and they'll be having shortness of breath and cough as well. The only difference between accelerated silicosis and chronic silicosis, chronic complicated silicosis, is the time period. That's the only difference. Apart from that, both are going to be symptomatic and both are going to present in almost a very similar way. Only it comes very fast. That's the only difference between accelerated silicosis and chronic complicated silicosis. Okay. What is the problem in acute silicoproteinosis? In acute silicoproteinosis, you know it's a very high level exposure. Because it's a high level exposure, such a high level silica dust particle will inhibit the alveolar macrophages from clearing surfactant proteins in the alveoli. So there will be reduced surfactant clearance. That is because of impairment of the function of the alveolar macrophages. Because of the reduced clearance of surfactant, these surfactant molecules are going to accumulate, and that will result in a disorder that is very, very similar to a pulmonary alveolar proteinosis. So that's why I told you sometimes you might have a productive cough here, possible. And you know very well, when you do a ball fluid here, how to definitively diagnose this? You're going to take a ball fluid. In this ball fluid, definitely you will see milky appearance of the ball, like how you saw in the pulmonary alveolar proteinosis also. In fact, this acute silicoproteinosis is one of the important differential diagnosis for PAP, and that's why it's also referred to as a secondary pulmonary alveolar proteinosis. So ball definitely is going to yield a milky fluid, and if you put them under PAS stain, they're going to show this PAS positive flocculent densities. These are surfactant molecules that are staining as PAS positive. They can be seen within the macrophages also, they can be seen outside the macrophages also. This is characteristic feature of acute silicoproteinosis, which means this is a characteristic feature of any disease that results in a pulmonary alveolar proteinosis. And how you are going to diagnose your chronic simple silicosis? Chronic simple silicosis is a little bit difficult to diagnose because the patient will be asymptomatic. They usually don't have the symptoms. Whenever you take an incidental radiograph, that is the time you're going to find out that the patient is having some issue. typically the patient will have upper lobe predominance, and very importantly, they will have nodules. These nodules can be either centrilobular or it can be perilymphatic distribution of the nodules. But very common is the centrilobular type only. We have discussed about the nodules in detail. There are three types of nodules, right? Centrilobular nodules, random nodules, and perilymphatic nodules. But here silicosis can produce perilymphatic as well as centrilobular, but centrilobular is much more common than the perilymphatic nodules. And these nodules, to call as a chronic simple silicosis, this nodular size should be less than 1 centimeter. Very, very important point. Remember, whenever the nodules are more than 1 centimeter, it's called a progressive massive fibrosis or a complicated silicosis. It's a complicated lesion. So you cannot call it as a simple lesion. Similarly, the same thing will apply to the Kohl-Weckers pneumoconiosis also, which you'll see there, where simple Kohl-Weckers pneumoconiosis, you will have a nodular size less than 1 centimeter. If it exceeds 1 centimeter, it will be called as progressive massive fibrosis only. It's complicated. So here the nodular size should be less than 1 centimeter. It's a very, very important point. Then only we can call it as a chronic simple silicosis. And in chest X-ray, you might see this characteristic eggshell calcification. I'll tell you the DD later on. You might see this characteristic eggshell calcification. Plus or minus, you can also result in formation of this conglomerate masses. Like many different masses coalesce together and accumulate, and if you see them, it might look like many different masses, but they are looking like a single mass. These are what we refer to as something called a conglomerate mass. So this is also one of characteristic feature of silicosis, but even though it's not specific for silicosis. And what you're going to see in the chronic complicated silicosis. Again, this disorder is also very common in the upper lobe only. At the same time, you will see nodules, again in the same distribution, maybe perilymphatic or maybe in the centrilobular zone, but these nodules will be more than 1 centimeter in diameter. Very, very, very important point. Only if it's more than 1 centimeter in diameter, you can call them as chronic complicated silicosis. If it's less than 1 centimeter, it becomes a chronic simple silicosis only. At the same time, this will be more in the periphery and they will enlarge towards the hilum. The growth will be towards the hilum. Starts in the periphery predominantly and they grow towards the hilum. So this is the characteristic feature of chronic complicated silicosis. And in accelerated silicosis, you get the same findings as that of chronic complicated silicosis. I told you already, everything will be very, very similar to that of chronic complicated silicosis, but it's only the time period where it happens. It's going to happen in a very, very fast latency period. It doesn't have that much latency period. Very, very soon it will happen. So that is 3 to 10 years only. But in these conditions, you can see it is 10 to 20 years. So that is the major difference between the chronic complicated and chronic simple silicosis, the latency period. Apart from that, the clinical feature wise, radiological feature wise, it's going to resemble the same. Fine. So these are the 4 major aspects of a silicosis, or 4 major types of silicosis clinically that we see. Then as I told you, silicosis increases the risk of tuberculosis also, which means this is what we're going to call it as something called a silicotuberculosis. And characteristic feature is they form a lot of cavitating lesions. Cavities is very common and often they are AFB negative. Clear? Usually, this is the only pneumoconiosis to have increased risk of tuberculosis. No other pneumoconiosis will have increased risk of tuberculosis, number 1. At the same time, they increase the risk of developing ILD and subsequent cor pulmonale also. Usually, this cor pulmonale risk is very, very high in patients who are having a chronic complicated silicosis or progressive massive fibrosis, and if they are having accelerated silicosis. In these 2 disorders, the risk of cor pulmonale ILD is very, very high. Apart from that, the risk is low in chronic simple silicosis and acute silicoproteinosis. Then they also increase the risk of primary lung cancer. Obviously, the risk is further increased with smoking. If the patient smokes, the risk is going to be very, very high. So I told you the most common type of lung cancer that any pneumoconiosis patients develop is the adenocarcinoma, which is a non-small cell lung cancer. And finally, silicosis patients also has an increased risk of developing rheumatoid arthritis So which means they also had increased risk of developing Kaplan syndrome. Remember, the most common cause of Kaplan syndrome in the world is also silicosis only. I didn't tell you one important point which will be usually seen in acute silicoproteinosis. It's a radiological point. I told you acute silicoproteinosis is a form of pulmonary alveolar proteinosis, that is secondary pulmonary alveolar proteinosis, which means in CT you're going to see this crazy pavement appearance, right? This is what you're going to see in the CT. You're going to see this crazy pavement appearance. So here also you can write in HRCT, you can see characteristic crazy pavement. Clear? We know what is crazy pavement. Crazy pavement means there will be ground glassing with interspersed normal areas in the entire secondary pulmonary lobule. At the same time, there will be interstitial thickening also. If you have a constellation of these features, this is what we call as crazy pavement. Not specific for pulmonary alveolar proteinosis, but originally described for pulmonary alveolar proteinosis. That is why that is the diagnosis you have to make in the exam. And remember, acute silicoproteinosis is also a type of PAP. It's a secondary pulmonary alveolar proteinosis. That's why here also you are seeing this crazy pavement appearance. Now, after seeing all these clinical features of and clinical types of silicosis, let us move on to seeing some images here. So these are the images which I want to show. The first image is an image of an acute silicoproteinosis, all right. So this is what you're going to see in acute silicoproteinosis. But what you are seeing is not suggestive of specifically acute silicoproteinosis. What you're seeing is just a consolidation. What do you mean by a consolidation? This fluffy kind of densities with silhouetting of the mediastinum as well as silhouetting of the diaphragm is there. So this whenever you see this fluffy kind of densities, which is an alveolar filling process. Here it is filled with this protein. That's why it's called a silicoproteinosis. It's similar to PAP, and that's what you're going to see, nothing else. So which means what you're going to see in acute silicoproteinosis is bilateral consolidation. That's it. But when you take a CT, you're going to see the real face of this consolidation, where you're going to see this typical ground glassing with interstitial and septal thickening will be there. Along with that, there will be a lot of interspersed normal areas like this. So this is what we are going to refer to as something called a crazy pavement appearance or a crazy paving pattern, which looks something similar to the crazy pavement which I have shown on the right side. This image we have seen already in the basics video, the previous one. So we are going to move on. It's not specific for silicosis or silicoproteinosis or pulmonary alveolar proteinosis for that matters. It's going to be seen in many other conditions where the mechanism is the same, like ARDS, interstitial pneumonia. Many examples are there. So this is a typical example of a eggshell calcification of the hilar nodes. Eggshell calcification of the hilar nodes. They ask you the DDs for eggshell calcification of hilar nodes. First thing, you tell silicosis. Apart from that, you have sarcoidosis. Apart from that, you have differential diagnosis in patients who have had Hodgkin lymphoma and who have underwent radiotherapy, which means after radiotherapy of Hodgkin lymphoma, you might develop this eggshell calcification. Typically happens after 9 to 10 years after radiotherapy. Then you can also develop in patients with cold workers pneumoconiosis, very rarely in patients with scleroderma, and very rarely with patients who are having fungal infections like histoplasmosis and blastomycosis. Alright. Then these are examples of conglomerate masses. You can see a lot of mass-like lesions that unite together to form a single mass-like appearance. That's what we refer to as conglomerate masses. Very characteristic of silicosis. Again, it can be seen in many other conditions like sarcoidosis, cold workers pneumoconiosis, and talcosis. So these are the 4 important DDs in exam. So if they ask you DDs for conglomerate masses, silicosis, sarcoidosis, cold workers pneumoconiosis, and talcosis. Then let us see the biopsy picture. In the biopsy picture, you can see the fibrotic nodule. So let me write it as N. This is the fibrotic nodule, and you can see surrounding concentric rings of collagen deposition. So this is a typical nodule that you see in a silicosis patient. And many other diseases also can produce this kind of nodule. So this is the characteristic central area that is having the fibrotic nodule, and the surrounding are having concentric rings of collagen deposition. Outside this nodule, you can see a lot of inflammatory infiltrate actively moving into this area. So this is a silica reaction. This is what the nodule is composed of. Fine. Now we have completed the silicosis aspect. Let us move on to the asbestosis. Asbestosis. Asbestosis wise, first you have to know the sources of asbestosis, where you can get this asbestos. People who are working in old naval ships, because that time many instruments in the naval ships are supposed to have this asbestos with them. At the same time, people who are working with old buildings, especially who are working in the process of demolition of these old buildings, because the ceiling, floor tiles, paint, many things contain asbestos, especially those who are built before 1990. So this is also a risk factor. And people who are working in certain automobile industries, automobile shops, also at high risk of developing asbestos. But typically in exams, you will get these naval ships are old building related work. And you have certain types of asbestos fibers. What are the types of asbestos fibers? First one is the serpentine type of fiber. Second one is the amphibole type of fiber. Remember, serpentine fibers are curved. At the same time, they are flexible fibers. Whereas amphibole fibers are straight and they are going to be rigid fibers. Clear? They are straight and rigid fibers, amphibole fibers. Serpentine fibers increase the risk of interstitial lung disease. Serpentine fibers increase the risk of primary lung cancer also, which I told you already, it will be usually non-small cell lung cancer, very commonly adenocarcinoma. Amphibole fibers also increase the risk of ILD. They also increase the risk of lung cancer, but they do increase the risk of mesothelioma also. Very, very important point. They do increase the risk of mesothelioma as well. So this is the fiber, the amphibole, straight, rigid fiber. An example of a serpentine fiber is what we refer to as a chrysolite. That's a type of fiber that is example of a serpentine fiber. An example of an amphibole fiber is crocidolite. This is an example of a amphibole fiber. Clear? Then, how they are going to appear in the tissue? This will write here itself. In the tissue, initially they will be swallowed by the alveolar macrophage. You have an alveolar macrophage here. This alveolar macrophage will swallow this asbestos fiber. Let me draw the asbestos fiber like this, and they are going to coat this asbestos fiber with ferritin. So this ferritin coated asbestos fiber is what we refer to as ferruginous bodies or ferruginous body. That's it. Clear? Very important point. Ferruginous body. And this ferruginous body you can see in the sputum as well as in the lung biopsy inside the alveoli. So they can ask you in any way. Then moving on to the clinical features. There are 4 important clinical features are there. One is the benign pleural plaques. Second one is the ILD. Third one is the lung cancer. And fourth one is the mesothelioma. These are the 4 different types of diseases you get from asbestosis. Number 1, what are the benign pleural plaques? As the name suggests, they are really benign, which means these are not pre-malignant or pre-cancerous lesions. Which means these are not pre-malignant and they are not going to result in any future mesothelioma. You have to be very, very careful. And asbestos-related pleural disease, usually where you will get in the lung. I'm asking about the site in the pleura where you will get. You will get typically in the lateral and the mediastinal pleura. Lateral and the mediastinal pleura. These are the 2 areas that are going to be very commonly affected with asbestos-related pleural disease, which means these plaques also are very, very common in the lateral and the mediastinal pleura only. And typically these plaques may have 2 appearances. If they are discrete, they typically look like a clover leaf-like appearance. Clover leaf-like appearance, which I will show you in the image. Or if they are united together and they form a big mass-like appearance, they do look like something called a candle dripping appearance. Candle dripping appearance. This is for large, confluent plaques. You might get a candle dripping like appearance also. And very, very important fact is the fact that these benign pleural plaques are not pre-malignant and you're not going to increase the risk of lung cancer or any mesothelioma, which means the mesothelioma is not going to arise from these disorders. You have to be very, very sure about that. But they do generally can produce restrictive lung disease. Even though they don't produce any much problem, but they still can produce a restrictive lung disease because this pleural plaques, these are fibrotic areas of pleura. So they will prevent the expansion of the lung properly, which means it's going to result in a extraparenchymal restrictive lung disease. So typically I told you in extraparenchymal restrictive lung disease, DLC will be normal, FVC will be reduced, but FEV1 by FVC will be maintained in the normal range, that is more than 0.7. Clear? So, but DLC will be typically normal in an extraparenchymal restriction. So, which you have seen already in the pulmonary function test. So, these are the things that you have to know. Fine. What about the ILD? ILD as such is a little common in asbestos. At the same time, they can progress to cor pulmonale. There is increased risk of cor pulmonale due to ILD. At the same time, they can also give rise to Kaplan syndrome. And this ILD of asbestosis is going to affect the lower lobe. Again, I told you it's a multiple times asked question. And what about the lung cancer? It's a bronchogenic carcinoma only, but very common it will be adenocarcinoma type, which is non-small cell lung cancer type, which is again, we have discussed repeatedly again and again, the most common cancer type in a pneumoconiosis patient is again this adenocarcinoma and non-small cell lung cancer only. And typically the risk is increased with smoking. And latency period, I told you, is approximately going to be around 20 years. Remember, and it is the most common cancer associated with asbestosis, not mesothelioma. Mesothelioma is exclusive cancer associated with asbestosis, but it's not the most common. Lung cancer, this adenocarcinoma, non-small cell lung cancer is the most common cancer associated with asbestos exposure. Mesothelioma. It's a malignant mesothelioma of the pleura. Generally, it tends to have a very, very poor prognosis. And again, these masses will be typically seen in the lateral and the mediastinal pleura only, which means asbestos-related diseases generally originate from the lateral and the mediastinal pleura. Remember, the latency period is very, very high, approximately around 30 years of latency is there. Clear? And it is not common as that of a lung cancer. I told you, even though mesothelioma is exclusive for asbestosis, it is not the most common cancer in asbestosis patients. It is the primary lung cancer that's going to be the most common cancer. Origin is going to be from the serosel cells lining the pleura, and typically there is no relationship with smoking. Whether the smoking is there in the patient or not doesn't matter. Asbestosis has nothing to do with that. If the patient smokes, it's not increased. There is no increased risk of mesothelioma. The smoking patient doesn't smoke means again there is no relevant feature like the patient will have a reduced risk of mesothelioma. Clear? Smoking has no etiological association with mesothelioma. All these are very, very important points. Similarly, at the same time, these patients are at no increased risk of tuberculosis also. No increased risk of tuberculosis for sure. Like how silicose increases the risk of tuberculosis. In fact, I told you it's the only pneumoconiosis that to increase the risk of tuberculosis, silicotuberculosis. But here, asbestosis or any other pneumoconiosis will not increase the risk of getting a tuberculosis. How are you going to treat? This mesothelioma treatment is what is going to be very important. Generally, it will be palliative because it's a very aggressive tumor and median survival is going to be hardly 2 to 4 months. So, treatment will be with pemetrexed. It's a congener of methotrexate. It's a folate antagonist. We treat pemetrexed plus cisplatin therapy. It's a platinum compound, all right? So, this is cisplatin therapy. If they fail the first line, then you can add or convert them to gemcitabine. You know, gemcitabine is a antimetabolitic drug. It's a pyrimidine antagonist. Along 5-fluorouracil, capecitabine, like cytarabine. Along with that, gemcitabine is a pyrimidine antagonist. We know that it's an antimetabolite drug. So it can be used as a second line if the first line treatments have failed. Apart from that, asbestosis itself has increased risk of other cancers like laryngeal cancer, stomach cancer and colon cancer. So asbestosis, apart from causing a lung cancer and mesothelioma, they also have increased risk of developing laryngeal cancer, stomach cancer as well as colon cancer. So these are some of the constellation of findings that are very, very important for asbestos related purposes. Now let us see some of the images that are related to asbestos. So you can see these are the benign pleural plaques. You can see these are calcified benign pleural plaques that look typically like a clover leaf appearance. And you can see a lot of lateral and mediastinal pleura are involved. At the same time, you can also notice that diaphragmatic pleura is also seriously involved in this disorder. So this is a benign pleural plaque, and again I'm telling you it is not a precancerous lesion or a pre-malignant lesion, and mesothelioma is not known to originate from this pleural plaques, but it can still cause your extraparenchymal restrictive lung disease. Next, you can see these are extensive pleural plaques. You can see this looks like a candle dripping appearance. And again, you can see this is very common in the lateral and the mediastinal pleura. And again, mesothelioma is also the same, where you can see here the lung is actually invaded from here. And this is actually could be confirmed only by CT and biopsy also. So this is an example of a mesothelioma, where lung is invaded. This is an example of a ferruginous body. Ferruginous body, where you can see this a golden beaded-like appearance. You have a straight fiber here, which is coated with ferritin, producing a golden beaded-like appearance within the alveoli or inside the macrophage or in the sputum. So this is a typical associated body called a ferruginous body. Then we'll move on to the next disorder, that is coal workers pneumoconiosis, which is also referred to as anthracosis. You know very well, the problem here is the coal dust. Coal dust, again, you know the exposure is going to be from the coal mines only. Typically, for example, if you take a Neyveli Lignite Corporation, so in NLC, their coal dust is very common. So even though the factory workers are given adequate protection, but still some people who may not use protection or may susceptible to this disease may still develop this coal workers pneumoconiosis. Coal dust is the primary problem here, and it can also come from a lot of urban centers, factories, and where they use coal, and from tobacco smoke also sometimes you might get, but all very, very, very rare. Currently it is coming from the coal mines only, very commonly. And as I told you, this coal dust is supposed to be the least fibrogenic particle. Least fibrogenic particle, which means to get the symptoms with coal dust, you need a huge amount of fibers, huge amount of coal dust to be deposited in the lung. Then only you will get this disease, otherwise you are not going to get this disease. It's one of the least fibrogenic particles. Disease spectrum, you have 2 to 3 types of diseases. Most importantly, there are 3. One is called the pulmonary anthracosis. Second one is the simple coal workers pneumoconiosis. Simple coal workers pneumoconiosis. And the third one, we call it as progressive massive fibrosis, like what you saw in silicosis. Simple silicosis, chronic simple silicosis, and chronic complicated silicosis, which is also called as progressive massive fibrosis. But what is pulmonary anthracosis? Typically, they tend to be asymptomatic, and there is no fibrosis, nor there will be any nodule formation here, which means there will be only localized areas of black colored pigmentation that only will be there here, which means you are only going to see the anthracotic pigment that will be seen in this called black pigment, anthracotic pigment, that is due to the coal dust deposition. You will be seeing in the interstitial tissue as well as the hilar nodes. That's all. Apart from that, no fibrosis or no nodules. Patient will be typically asymptomatic. This is what we refer to as pulmonary anthracosis. In simple coal workers pneumoconiosis, you will see this fibrotic nodules like what you see in the silicosis. I showed you a fibrotic nodule there. You will see a fibrotic nodule. Typically, it should be less than 1 centimeter. Then only you will put under simple coal workers pneumoconiosis. If it is having a fibrotic nodule more than 1 centimeter, that will be a progressive massive fibrosis, which is also referred to as something called a crippling lung disease. Obviously, it's going to cripple the patient. That's why it's called a crippling lung disease. One of the oldest pneumoconiosis, coal workers pneumoconiosis. Remember, these patients generally tend to be asymptomatic, or even if they are symptomatic, the symptoms tend to be extremely less. But these patients will definitely be symptomatic and there will be progressive deterioration. At the same time, this progressive massive fibrous patients has a very high risk of developing carpal. Obviously, this is a severe form of fibrosis. And overall, this coal workers pneumoconiosis or anthracosis means the lung is going to be black because of the coal dust accumulation. So that's why it's also referred to as black lung disease. And the macrophages that accumulate this dust particles are what we refer to as dust cells. So all these points are very important to understand. Finally, coal workers pneumoconiosis patients have increased risk of developing rheumatoid arthritis and Kaplan syndrome. In fact, the first case of Kaplan syndrome was discovered and it is first explained with the case of coal workers pneumoconiosis only. Second, they also have increased risk of developing ILD. Because of that, they have increased risk of developing carpulmonale also. But they do not have any increased risk of developing tuberculosis. They don't have any increased risk of developing mesothelioma. But cancer alone, this lung cancer alone is highly controversial because a lot of old books tell there is no relationship with increased lung cancer, but a lot of modern articles tell there is some increased risk of developing lung cancer in these patients. Clear? So, but anyway, if you take all the pneumoconiosis, this coal workers pneumoconiosis is going to have the least risk of developing lung cancer for sure. So these are some of the other spectrum of disorders that you have to know. Let us see some images. So what you are seeing here? You are seeing here a simple coal workers pneumoconiosis where you can see the nodule size here is less than 1 centimeter. You can see the nodules over here. These are black fibrotic nodules that you are seeing here in the centrilobular distribution. This is typically less than 1 centimeter. And this is progressive massive fibrosis. Surely here you can see the nodular size is more than 1 centimeter for sure. There is no doubt about that. And these patients are going to be very symptomatic and progressive lung disease, and they are going to develop carpulmonale also over time and death by respiratory failure. And you can see this is a anthracotic pigment, which I am shading here, are all black pigments. That is due to accumulation of macrophages that contain the coal dust particles called as dust cells. They accumulate and they produce this black pigmentation in the interstitium and the alveoli. So these are all about your coal workers pneumoconiosis. Next, we can move on to the final pneumoconiosis, that is berylliosis. Berylliosis, sources wise, it comes from only two sources. One is the nuclear industry and aerospace industry, very commonly, currently. And it's going to resemble absolutely sarcoidosis. It's one disease that typically mimics sarcoidosis. It's very, very difficult to differentiate from sarcoidosis, which means it's also going to produce a multisystemic granulomatous disease. And this granulomatous, like sarcoidosis, is going to be non-caseating granulomas. At the same time, remember, these patients also produce lymphadenopathy to confuse the picture. So they have multisystemic granulomas which are non-caseating, and it's not TB, and the patient is going to have lymphadenopathy also. Typically hilar nodes and all will be there, which means it's going to extremely resemble sarcoidosis. You are going to have a tough time in differentiating this disease from sarcoidosis. That's why we have a diagnostic criteria for diagnosing berylliosis. The number one is the history of beryllium exposure. History of beryllium exposure. Number two, the patient is going to have non-caseating granulomas in biopsy. When you take a biopsy from this lymph node or from the lung that is affected, you're going to result in a non-caseating granuloma in the finding. Number three, positive B-Lipt test. What do you mean by positive B-Lipt? This is called beryllium lymphocyte proliferation test. Beryllium lymphocyte proliferation test. So typically this test will be done in mononuclear cells that are obtained either from the peripheral smear or obtained from the BAL fluid, bronchoalveolar lavage fluid. Typically, remember, this test is very, very important. This is needed to diagnose berylliosis and to differentiate from sarcoidosis. Clear? Very, very important point. Treatment wise, why this is very important? Again, because this is the only pneumoconiosis that can be treated with steroids and immunosuppressants like azathioprine. For example, azathioprine. So which means it will be treated like sarcoidosis only, clear, to reduce the granulomatous response. So this is the only pneumoconiosis which has a treatment in the form of steroids and immunosuppressants. The only disease that we have to know now is the talcosis. Talcosis is the only disease that we have to know. Literally, it's a very rare disease, but it has been identified in the 19th century itself. But it's a very rare disease, to be honest, in the current era. But it can happen from anything that uses this talc. Talc is nothing but a magnesium silicate. That's what we call talc. And it is mixed in a certain proportion. And you can see this talc in many places. You can see in tablets also, where it is used as a bulking agent when you swallow, especially in benzodiazepines, promethazines. This talc is very commonly used. At the same time, this talc is also a very important component of a cosmetic agent like talcum powder now, where I tell an interesting case history where we have found out a talcosis, where a very young girl, around 16 to 17 years of age, who came with recurrent pneumonia-like picture, who has been treated with again and again antibiotics for multiple times in her past. And at the same time, she also had progressive shortness of breath and cough, but without expectoration, dry cough. So when we took a CT, it showed like small nodular pattern. Many of my juniors told it's a miliary TB, but miliary TB has a random distribution of nodules, but this was more of a central lobular distribution. But so we want to take a CT to confirm that. CT showed it's not a random distribution of nodules everywhere else. It was small central lobular nodules in few areas. So we want to take a biopsy. Biopsy showed some giant cells, maybe a granulomatous reaction, but it was a non-casseting granuloma. I still was not convinced with the fact that it's a TB, even though my professor told like you have to start with ATT. I still want to confirm. So we sent for the polarized microscope because I had one that peculiar history because she used to bath 3 times a day. In fact, some days she used to bath 4 times a day. That is because of the ritual she has according to her religion. And she uses plenty of cosmetic talcum powder application because the time they came to the hospital, there was so much of talcum powder application. And there was something suspicious. We couldn't suspect the talcosis, but there was something suspicious. And when we looked out on all the literature data and we found out, and it has to be found out through polarized microscopy. When you did a polarized microscopy, it was the talcum powder which was still confirmed with the spectroscopy, which showed magnesium and silicon, that silicate in the appropriate proportion that is equivalent to that of the talc. This is one case. But talcosis has been reported in patients who are using heroin also. In heroin, sometimes this talc has been used as a contaminant to increase the weight of the heroin so that you can sell it for more price. It's a contaminant. So in heroin uses intravenous injections, or patients sometimes they crush the tablets that are supposed to be oral. They crush it and mix it with water and they do intravenous injections, especially those who are addicted to benzodiazepines and all. So this IV drug abusers also can develop a talcosis. So there are 2 ways. One is inhalational way of developing talcosis, and second one you can also develop through intravenous route. You can develop the talcosis. So this is very common in intravenous drug abuses like heroin, benzodiazepines, anything. When they crush the tablets and use heroin, it's a contaminant. So typically they are going to produce a granulomatous reaction. If it's intravenous, typically this granulomatous reaction will be around the perivascular zone. So if you take this is the vessel, small vessel, around the vascular region, you will see a granulomatous reaction. Why? Because this talc initially in the vessels will come out of the vessels and accumulate in the interstitium, where you will get a granulomatous reaction because it's a foreign material. So when you examine this granulomatous material under polarized microscope, you can see this is a polarizable substance. You can see within the granulomas, you can see a polarizable substance. And it is not a gaseous substance. That's what is going to tell you the difference between a tuberculosis. You can confirm that polarizable substance is a talc using spectroscopy. So now we can see the image. You can see in this, you can see a lot of these giant cells. This is a giant cell, multinucleate giant cell. And in the central, you can see some foreign material, but we don't know what is it, but you are seeing a giant cell, multinucleate giant cell here. But when we put it in polarized microscope, you can see a lot of substances are actually polarized. These white substances, this is what we call polarizable substance in polarized microscope. So near the multinucleate giant cells, you are seeing all these substances. Clear? Now, this is a scanning electron microscopy image. This is a scanning electron microscopy image where you can actually depict the talc using the density, electron density of the substance. The talc has some kind of density which can be proved by scanning electron microscope also. Finally, this is a spectroscopy image where you can see the magnesium and silicon in appropriate ratio, which means TAL contains, I told you, it contains magnesium silicate. And if you prove this, again, you can prove this is a talcosis. Once again, talcosis is a very difficult disease to prove. It's not so easy to prove, but you need a very, very high degree of suspicion, especially when you are seeing a centrilobular nodule appearance. So let us see a CT image. So you can see this is one of the examples of a CT image where you can see this kind of small nodules. You can see these are nodules that are typically tends to be appearing like centrilobular. You can see a lot of nodules. Clear? Lots of nodules you can see like this. So this is also one important thing that you have to note about talcosis, because this is going to give the first suspicion for you regarding talcosis, because you are going to see the nodules, micronodules. Usually it will be less than 1 millimeter in diameter in the lung. So with this we are completing the section on pneumoconiosis. We have seen 5 important disorders, that is silicosis, asbestosis, your coal workers pneumoconiosis, berylliosis, and finally some extra edge information on talcosis also. So we can close this and sign off this session, and we'll move on to the next session, which is on hypersensitivity pneumonitis.